done in a doctor's office. So labeled immunoassay have these EIA and ELISA type testing have really revolutionized a lot of the laboratory stuff, making it quicker. Okay, instead of going to the doctor's office, he collects a sample, he sends it to the lab brings it in and processes it, takes it to the place where it's going to be run, runs it, and reports it back out. And so you're talking at least a 1-day turnaround time for almost everything. A lot of these labeled immunoassays can be done at patient bedside. Many of them can be done on a finger stick, as we discussed yesterday. If you do it with whole blood, it's wave testing, and if you do it with spun blood, it becomes moderate complexity. But basically, these can be done by pretty much anyone at the doctor's office. If you're doing wave testing, the current rule is anyone who has been properly trained and is periodically proficiency tested can perform the test. They did add the periodically proficiency tested not too long ago, a couple of years ago, just because it's like somebody would come in, they'd train them, and then they never were tested again to make sure they were doing it correctly. So now there is pretty much an annual review. Everyone who does wave testing has to be recertified annually. And even in the hospitals, this is becoming huge. That's point of care testing. We have 3 people who run our point of care testing. It takes them, now they all work the bench too, but it's basically a full-time and a part-time position together. It takes basically one full body just to keep track of the paperwork. But every nurse who does finger stick glucoses, every ER tech who does a urine preg test, anybody who does any point of care testing must be monitored, and once a year has to recertify on point of care testing. These labeled immunoassays, I don't want to say they're idiot proof, but they're, inexperienced resistance. So people who are not really into doing lab testing, who don't understand all the ins and outs and why we do stuff, they pretty much allow for us to let this type of testing go out into the more general medical community without having to be terrified that they're really screwing it up. As long as you're following the basics, you're in good shape. So we've got some definitions. And again, this is where I said I kind of feel like some of these definitions and pieces are sort of scattered everywhere. I think I may collect them next year for a sort of overview of testing and then break down the methodologies. An analyte is what we're looking for. That is not a term that is in any way, shape, or form restricted to this type of assay. Anything we're looking for is an analyte. If we're doing a glucose test, the analyte is glucose. Okay. Competitive immunoassays, we talked about these a little bit. Reagents and patient specimens are added at the same time. The labeled antigen competes with the unlabeled patient specimens. And yes, I know I went over it before. We're going over it again. I'm hoping it will make it stick. Okay. Non-competitive immunoassays, this is the kit antibody is absorbed to the solid phase. Then unlabeled patient antigen is added, followed by a second kit labeled antibody. Heterogeneous enzymes require a wash step to separate the free from the bound. Okay. A homogeneous enzyme assay doesn't require a wash step. The enzyme decreases as the antigen and antibody bind. The homogeneous assays are not as sensitive. Basically, the unwashed is a lot harder to read, or you don't get quite as clear a reaction on it. So most of ours are heterogeneous enzyme assays. The benefit to these is that there is usually a single step. Okay, if you add a wash step, it's a moderately complex test, and most people can't do it. So these homogeneous ones, even though they're not the best or not as good, usually they're good enough to do the job, to do the testing. And if it comes up negative and you still have the symptoms, doc's gonna treat you anyway. Okay. Or he's gonna repeat the test in a couple of days or a couple of weeks. Non-competitive immunoassay, the sandwich technique. Okay. Yes, I know I talked about it before, we're talking about it again. Basically, we put the antigens on there, and we add the patient antibody, okay, and we cook it.
Cook it?
You incubate it. It might cook at room temperature. Yeah. Basically, you incubate it for a period of time. Then we add our anti-human antiglobulin, and we wash away anything that wasn't there. Then we add our substrate, aren't those cute, little hearts, okay? And our chemical reaction occurs. So basically the blue, okay, so when we did our mycoplasma / H. pylori testing yesterday, the well was coated with our antigen, either mycoplasma or H. They were all mycoplasma, right? I told you that, they're all mycoplasma. So we coat it with mycoplasma, we put the patient antibody in there. The conjugate is the human antibody that we've labeled with, we've labeled it with our conjugate, we've labeled it with an enzyme. We then put this in here, and if this is attached, we wind up with blue. If it's not attached, it'll wash away, and we wind up with nothing. Make sense? Yes?
What is
The
the substrate?
substrate is basically, it's something that turns blue in the presence of this.
I thought the conjugate was the, never mind, so the conjugate and substrate combined to create the blue.
Right, conjugate plus substrate equal blue. And we do a wash step in between here to wash it all away, to wash any unbound away. The amount of color change is directly proportional to the concentration of antibody present. We can actually do a quantitative sandwich method, and like I said, that's what we do on the COVAX e-modules. And I'm sure some of the other analyzers out there, I just don't know chemistry analyzers that well to know which ones are which. That we can measure how much color change takes place, and that will tell us how much is present. And truthfully, if you've got a person who's got a really good whopping case of mycoplasma, that's going to turn dark blue pretty fast. Most people, it's going to be kind of a faint, put it on a white piece of paper, call everybody over and go, I don't know, what do you think? I don't know, yeah, maybe. Yes?
How do you rule out crossover?
You don't.
You can't?
You don't.
Okay.
You design the test so that it doesn't interfere. Solid phase can also be coated with the antibody if I'm looking for antigen. Like I said, all of these tests are reversible. You know, we can always start with an antibody, add the antigen, then add an anti-antigen antibody. Okay, so if I was doing it the other way around, what I would have is this would be antibody, add the patient, and the antigen would bind. Then this antibody, instead of being anti-human globulin antibody, would be whatever my antigen is. Does that make sense? Okay, so you just have to kind of, basically, this is our target antibody to bind to whatever we have here. If we're looking for an antibody, it's got to bind to the FC portion of the antibody. If we're looking for an antigen, we just put a tagged antibody against that particular antigen to switch that around. Okay. So we can go both ways. Enzyme immunoassay, also known as ELISA or enzyme-linked immunosorbent assay. Pretty much the terms are interchangeable. The immunosorbent assay is a little bit, technically, I guess it's a little bit different. We just use the terms interchangeably. Okay. We're going to use an enzyme. Okay. So usually we're looking for a blue or a pink color. Those are the two most common enzymes that we use. We're gonna use this to detect hormones, drugs, tumor markers. We can quantitate the color change using a spectrophotometer. There's good sensitivity on these. They pretty much pick a lot of stuff up. And limited danger as far as screwing them up. They're usually pretty specific, and they're quite quick. Some of our older methods, especially for hormones, took forever, and tumor markers can still take forever with a lot of our other methods. But frankly, these enzyme immunoassays are fairly quick, fairly good screening tests. A lot of our tumor markers and things like that, molecular diagnostics is taking over. But one of the biggest advantages of the EIA is when we put it on a kit test. And that's what most of our ELISAs are, is the kit test. But we can put this on an automated analyzer, gives us a lot of really useful kind of stuff, yes.
Will it detect, like, if it's like a solid tumor and it's not like floating in the blood, so then will those markers still be in the blood, or is it just on the tumor?
It depends. The answer to that question is depends on what one we're looking at. Some of the tumor markers are actually in the blood. CEA, CA19-9, CA27, those are the ones I can think of off the top of my head that are floating in the blood that we can find. Other ones you can actually take a piece of tissue and grind it up. Our job is so fascinating. You can actually grind it up and put it into a solution and then test that.
So you need the biopsy of it?
Sometimes,
the actual,
yeah,
okay.
the biopsy, yeah. Sometimes we can do that against a slide. They'll take, in histology, when they prepare a slide, what they do is somebody grosses it. They cut off the pieces that look funky. And then those will be embedded into paraffin. And then they take them over to what's called a microtome, and they literally, you go like this, and it slices them into basically 1 cell thick slices, which it then floats onto water, and you take the slide and kind of come up underneath of it and let it go on the slide, and then you fix it and stain it. Well, what you can also do is you can fix it, and then you can take like these enzyme link, that would be your antigen on your slide, is your tissue, and then you would put the labeled antibody on there, and you could put your substrate on top of that, and it will sometimes give you a color change. It's immunohistochemistry, and it is big. There's a lot of those kind of immunohistostains coming up that they can take a piece and look it on there, where you put it on the slide and put this stain on top of it, and it'll tell you if it's cancerous or not.
Would that be at a reference lab or at a hospital?
No, we do it at the hospital.
Oh, really?
Yeah, it'd be in histology though. And if you're interested in histology, there's a lot of histotech jobs out there. And right now there are like almost no histotech schools anywhere, so 90% of histotech jobs are on the job training. So there's a lot of labs, if you can get into it, make friends with a pathologist. And if you're interested in it, like I said, it's a good field, and it's growing, so, yeah.
I thought histotechnologist was either a bachelor or a master's level.
Nope. Didn't have to be.
The
You can be.
histologist was the doctorate level.
It depends on what you're doing, what it has to be, but in a hospital laboratory, we've got MLTs, we've got MAs. All you have to have is an associate's in science.
Seriously?
You have to have an associate's in science, and then on the job training, and then you sit for your boards. Now, that's an assistant. Obviously, you can go then to the bachelor's level, the master's level. The higher up you go, the more you're gonna do. But, so you can, okay. Competitive EIA. Okay, here's where we've got our antigen on our solid phase. We've got our labeled ones, and then the patient supplies the unlabeled ones, all right? And they compete for the sites. So the less patient antibody that's present, the more sites that will be open for our enzyme labeled antibodies, okay? So basically this antibody is the same as this antibody, it's just we made this one in a lab and hooked something to it, okay? So they're gonna go in and they're gonna compete for these binding sites. So if the patient has a lot, there's not room for the enzyme labeled ones to get in there. And if the patient doesn't have a lot, well, there's plenty of space. So it's kind of going to be an inverse reaction. The more of the enzyme labeled ones that hooked on there, the less the patient had. Does that make sense? Just kind of backwards. Then, of course, we're going to add the substrate. We have to add the substrate to get the color change. We're going to wash those guys away, and the substrate's going to come down, and that actually hooked to the wrong place. Oh, okay, no, it hooks onto all of them, and it only reacts with the enzyme one. Sorry, it's like, what's going on here? No, okay.
Is the substrate always necessary, or sometimes is the reaction between the antibody and the antigen?
In an
creating the
enzyme
color?
labeled assay, it's necessary because that's the definition of the methodology, that we are using an enzyme. So in these enzyme labeled ones, then we have to use the substrate. In other methodologies, the same things happen, it's just we're attaching something else or measuring it a different way. Okay. So in this particular methodology, yeah, the substrate's necessary because that's the whole basis of the test.
Okay.
Okay. But now, do the competitive assays and the non-competitive assays work with other methodologies? Yes, absolutely. Yes.
So in the principle of the competitive EIA, if there was no color change whatsoever, there was 2 in the antibodies.
If there was no
in the
color
patient.
change whatsoever, it would mean he's really, really high. He's got a lot.
Yeah, okay.
Heterogeneous EIA or ELISA, the enzyme labeled reagent does not react in the initial antigen antibody. Okay. Example 1, we're going to do a competitive EIA. Our enzyme labeled antigen competes with the unlabeled antigen for a limited amount of antibody sites. We wash it away, and the amount of antigen is inversely proportional to the concentration of the substance being measured. It's very, very specific. Okay. Those are a couple terms that we didn't discuss. Non-competitive EIA, which is also ELISA, the kit antibody and patient antigen, and enzyme labeled antibody, which is most commonly used. It's highly sensitive. I love this slide. I really don't like this slide though. Okay. Competitive ones, very high specificity. Okay. What is specificity? What does that mean?
Specific to that disease.
Okay. Am I more likely to get false positives or false negatives with that one?
False negatives.
False
Negative.
negatives, right? Sensitivity,
Would be positive. Positives.
and specificity. Two very important terms when we're talking about serology testing. Sensitivity. How much of what we're looking for has to be present before I can find it? Okay. Specificity is how much cross reaction am I going to get? What are the chances that I'm going to detect something that is not really what I'm looking for? In a perfect world, it would be 99.9% sensitive and 99.9% specific. Bless you. Okay? How many tests out there you think we get that with? Usually it's a trade-off. You have to kind of figure out how much you're willing to give up. Okay? When we're doing a screening test, we want it to be highly sensitive. Sensitivity is our goal. We really want it sensitive. We don't want any false negatives. We don't want to miss anything. Okay, so on a screening test, on a perfect test, we want high both of these. On a screening test, we want to make sure we catch everybody who's got the disease. Even if we pick up the occasional one who doesn't really have it. Specificity, if I run a test, this is going to be more our confirmation or our confirmatory test. Something with a high specificity. If I get a positive reaction, you got it. That's all there is to it. However, if you don't have a really strong case of it, I might miss it. They also tend to be a little more expensive, our confirmation tested. The thing is, RPRs is the best example I can give you. A rapid reogon test tests for syphilis. It's super cheap, super fast, super easy. But the list of things that can cause a positive RPR that are not syphilis is 1.5 miles long, one of which is pregnancy. And who are we screening for syphilis? All of our pregnant people. Okay. So our RPRs, a very cheap, very quick, very easy screening test. If you've got syphilis, it's going to catch you. It's going to catch pretty much 98, I think it's 98% sensitive. It catches pretty much everybody who has syphilis. Unfortunately, it also catches a lot of people who don't have syphilis. So what we have to do is we run our RPR, and if it comes up positive, we send it for a more specific test to confirm it, just like HIV. Our screening test, although the screening tests these days, their specificity is pretty good. If you get a positive screen, the chances of getting a negative confirmation are slim. But we do not report out a reactive HIV test. We report it as non-reactive, or we report it as presumptive. You cannot actually report it as positive or reactive until after your Western blot comes back. So yes.
Are we going to be given a list of which exams or which tests that we can run and then move on down the line without a doctor's order? Or is that just something that we're going to have to learn while we're on the job?
I'm not sure what you're asking me.
Reflexes.
Oh, reflex tests. Oh, yeah, that's built into the system.
Okay.
It's built into the system. You run it, and it'll say, run a TSH reflex.
Okay.
Yeah. And certain ones just automatically. RPR is always reflex. HIV is always reflex. Those are the two I can think of off the top of my head. I'm sure there's others. And then there are ones that the doctors can order with a reflex automatically. A strep A automatically reflexes to culture.
Is a mono always a reflex to an Epstein-Barr?
No, that one's pretty much doctor's request. And there's, CDC's coming out with a bunch of new rulings on Epstein-Barr testing. So, basically they're saying it's gonna base on age. If they're over 13, you're gonna do one thing. If they're under 13, you're gonna do something else. But I don't know how long those will take from where they are now to when they actually get to the lab and say this is what you have to do.
Is there a reason? Is Epstein-Barr not significant?
It's not as significant in adults. So, or actually it needs to be tested for differently in adults because it's more of a concern for lymphomas if we see it in adults. So there's some extra testing being done. Did you have a question?
Yeah, non-competitive still seems competitive to me when you read it.
Okay. Non-competitive, basically when we add the kit antibody, we add the patient antigen, and we add the enzyme labeled antibody. The enzyme labeled antibody is not against the antigen. Okay,
It's for the other antibody? Is it like a sandwich thing?
yeah. When we have a competitive,
They're fighting for spots.
right, when we have the non-competitive, that's the sandwich one.
Okay,
Okay, where our labeled enzyme is going to be against what we're looking for in the patient.
I didn't understand the way it was worded.
Okay, yeah, I didn't either. So, the enzyme label is going to be against what we're looking for in the patient in a non-competitive one. In the competitive one, the enzyme labeled antibody, or the enzyme labeled thing, is going to be the same thing as what we're looking for in the patient. Okay? Yeah, it took me a minute of reading those before I got that one figured out too. Yeah.
So you know people who went RDs or set up tents or like blood donating centers
Uh-huh.
where they test or like they can shoot tests for like HIV or AIDS. If it comes back positive, do they just tell you to go, do further testing?
They refer you.
Okay.
They refer you. And if you do a blood donation and you come back P24 positive, they will contact you and tell you. Actually, I believe they report it to state, I think is what they do, and then the health department will contact you.
So they won't specifically tell you if you have.
They won't know for 3 or 4 days after you donate. Yeah, so it's the blood basically, when they get it at the blood donation, they just throw it into a box and then,
My friend worked at a plasma center and she said that they do a test on you before you donate and.
okay, plasma centers are different. Those are for profit.
Okay.
Yeah, those are for profit, and yeah, those they will do the testing, and if it is positive, they will refer you. They will defer you as a donor
Yeah.
and refer you to assistance. Great, you had a question?
Unlabeled, or no, non-competitive unlabeled, that goes against what?
Okay,
That was something you just said like a minute ago, I just
okay,
forgot half.
that's okay. The non-competitive, our labeled antibody is against what we're looking for from the patient.
Okay,
In our competitive assay, our labeled antibody is the same thing as what we're looking for in the patient. Or our labeled thing is the same thing as what we're looking for in the patient. Okay, so if I'm looking for Epstein-Barr antigen in a patient, what I would be competing with was labeled Epstein-Barr antigen. If I were looking for Epstein-Barr antibody in the patient, I would be adding a labeled Epstein-Barr antibody
okay.
in for the competitive assay. Yes.
In the non-competitive labeled immunoassay sandwich technique,
Uh-huh.
essentially
Wait.
the antibody that we're looking for becomes the antigen to the human antibody.
Yes. Not essentially, exactly. All right. Capture assays. The biggest part about our capture assays, the ones that we use, these, again, this is also a sandwich assay, it's just on a solid phase. This is what a lot of blood bank, or what Immunocore's blood banking stuff is all based on. Rapid immunoassays, these basically are point of care. It just means that we've taken the immunoassay, the EIA test, and we put it in a little kit and said add 2 drops, add 4 drops, add a drop, wait 5 minutes. Or in some cases, put a drop of blood, wait 5 minutes. Okay, so they're basically, we're going to have, it's going to be put onto a nitrocellulose membrane, just basically absorbent paper. You're gonna have the antigen or the antibody on there. You're gonna add the you're gonna add the patient sample and look for a change in color. Most of these are going to be qualitative. You're not gonna get quantitative stuff with these. These are a you got it, you don't. Basically your EPT. Okay, it's your basic EPT test. I love the one that, and I know they're way more sophisticated now. The biggest one that came out was it gives you a plus sign if you're pregnant and a minus sign if you're not. The minus sign's the control line, and they put the test line going up and down so that if it reacted, you got a plus sign. Now, how the one that says pregnant, not pregnant works, I don't know how that one works at all. Unless the pregnant is your control and the non, I don't know how that one works.
For those mothers who can't read the sign.
Yeah, for people who shouldn't be reproducing anyway.
Have a lot of money.
And have a lot of money, exactly. And it's fanciness. Oh, look at the, or the curved one. Who cares? You're gonna put pee on it, you know?
Yeah, they got the one to tell you if you're over like 5 weeks or
Yeah.
something. Like I had got it when I was pregnant and I found out, I didn't believe I was over 5 weeks. I'm like, no, this can't be true. And I went to the doctor, I was 7 weeks.
Yeah.
Like I did not believe it.
Well, the ones these days are so sensitive. I mean, they can tell. There's a big thing that there's so many more miscarriages. I wonder how many more miscarriages there actually are, and how much is just because you used to be a good 2-3 months along before you figured out you were pregnant. And, you know, so there were probably a lot of miscarriages that they just didn't know they were pregnant yet, thought it was a heavy period and moved on. Now they can tell you practically, you know, after you've had sex if you're pregnant or not.
Yeah.
I mean, it's, you know, it's within a day or two that they can predict it these days, so. What's that?
My friend found out she was 4 days. I was like, oh my god.
Yeah, you know, and truthfully, I wouldn't wanna know, because honestly, most miscarriages occur within that first 6 to 8 weeks, you know, and definitely within the first trimester. So, you know, you're setting yourself up for this emotional,
I think 1 in 4 women have miscarriages.
yeah. And as I said, I don't think that there's really an increased number of miscarriages. I think you just know so much sooner that, you know, in my mother's era, you know,
You didn't know. Yeah.
you didn't know till you were, what, 3 months along?
They started to show.
Yeah, pretty much, you know, until you had missed several periods. So, I mean, now they're finding out so early. I think that we just, I worry because it does, I mean, it's got to be emotionally devastating,
Yeah.
Yeah.
you know, and.
Cause I didn't find, I was just, like, period was just on, off. And I'm
Mhm.
like, something ain't right. But then I had pain too, like sharp pain a lot.
Yeah.
And I was like, maybe I need to check. And then that's when I found out, and
Yeah.
I was like, but if I would have found out sooner, they could have helped me. But if I didn't find out nothing and I just kept going on, I could have died.
Yeah. Oh, was yours ectopic?
Yeah.
Yeah, those, now there's a case when being able to know quickly is important. You know, there's a case where it's definitively you have to, because if you don't get in there and remove the fetus from that tube, it can kill the mother.
Mhm.
So that's, you know, one case where, you know, it's an unfortunate circumstance, and I'm sorry anyone has to go through that, because it's horrible. But, you know, that is one case. But like I said, I worry, you know, the thing that sticks in my brain forever was drawing the 13-year-old girl who just had a baby, and she was so happy because she'd been trying forever.
Huh?
What?
The 13-year-old girl.
I've been trying for so long. Oh my God, that's just disgusting.
It's like, I've got a 9-year-old. Duh.
Yeah, I couldn't, I mean, but she was thrilled, she had the baby, and it's just like, oh honey,
There's the parenting in that.
yeah, oh honey, yeah, you. There's
Should
not.
auditioning to get on that TV.
What's that?
Never mind. Bad comment.
Yeah,
Bad
that's
comment.
what about. I mean, you know,
When I work for baby stores, there'll be like, 12-year-olds, and there's balloons and flowers, and I'm like, oh my god.
this is not something to celebrate, honey. You know, I just,
That's too young.
I mean, I think they need to be finding the fathers and beating the stuffing out of them boys.
You won't be finding that father.
Well, yeah. Probably not. But, it's.
Was the father there with her?
I was in there for 2 minutes drawing the blood now, so I don't know beyond that. I was just
Probably in middle school.
What's that?
He was probably in middle school.
Yeah, he was probably at school.
I can get it. I had a friend having a mom at like 23. I can't even imagine being there.
When I was 13, I didn't want anything to do with boys. I was busy.
It has nothing to do with the boys at that age. It has to do with, oh, babies give attention.
I know. Well, I mean, I know all the ins and outs of tea, but I just. All right. Anyway, we digress. Immunoassays, homogeneous enzyme immunoassay, basically where there's no separation step involved. We're kind of repeating ourselves here. We have an antibody system. This is kind of a direct. We have an antigen, we have an antibody, we have a measuring system. We're done. Okay. They're less sensitive, but they are rapid, simple to perform. Simple to perform, and adapt easily to automation. The chief use has been for determination of low molecular weight analyzed like hormones, therapeutic drugs, and drugs of abuse. Okay, that's not necessarily true anymore, but again, a lot of different test methodologies are coming out. But a lot of our EIAs, a lot of our therapeutic drugs we do by EIA, simply because it's quick and easy. You know, dilantins, carbamazepine, trying to think of which other ones are on that. Parathyroid hormones are on there, estradiol, FSH, LH. All of those are done with enzyme immunoassay. Okay. Rapid, fairly straightforward, pretty easy to do. Put it into rack, put the rack on the machine, push it the button. Okay, well, okay, you have to calibrate first, but yeah, fairly straightforward. And again, the methodology is sensitive enough that will give the doctor a good enough result that he can act on it. You know, we don't have to have a perfect test result, we just have to have one that is adequate to give the doctor the information he needs to act on. Okay. Fluorescent immunoassay, all of the same stuff we've talked about, competitive, non-competitive, all of that still applies, except instead of sticking a pretty little substrate on there and looking for a blue color, we're going to label it with a fluorescent tag. It's going to glow in the dark. Okay? A lot of them are green. They're kind of this yellowish green. Fluorescein dye is yellowish green. And so basically, what we're going to do is we're going to run our test. You can use a spectrophotometer with a fluorescent filter, or a lot of times what we use is a fluorescent microscope. We actually have a fluorescent microscope that someone donated to the college. It's awesome. That is not something a lot of people get to see. Even in their clinical sites, a lot of them won't have the fluorescent scopes anymore. But they do use a fluorescein dye, and basically instead of the light coming up from underneath of it, what you're going to do is you're going to use a UV light bulb, a UV lamp, and it's going to shine the light down on it, and anything that fluoresces is going to bounce back, and that's what's going to come through the ocular for you to look at. So you're not looking directly into a black light, you're looking at what's bouncing off of the fluorescent stuff. We use it for microorganisms, particularly this is the basis for our fluorescent treponemal antibody test. And that is our confirmation for our PR. So you get a positive syphilis reagin test, and then we send that out for confirmation to get and it will do an FTA, and it looks for the little wigglies in the scope. I don't think we have any FTA slides, but she has is ANA slides. Again, you can look for tumor markers with this, either on and those are pretty much the ones that we would be doing on a histology or a section, a slide from a biopsy, okay? Where you would flood it with an antibody that is labeled with a fluorescein dye, and then look at it under a fluorescent scope to look for the presence of that marker.
Are you looking for clumping?
No.
Because they're all labeled and they're all going to.
No, you're not looking for clumping in this one, you're looking for color.
Is it only fluoresce if it makes?
If it's positive. Mm-hmm. Let me see.
Otherwise it would be black.
No, they have a background fluorescence just because everything fluoresces a little bit. Let me see, I think she's got pictures in here. She has got pictures. Okay. So here's our fluorescent microscope. That's nice. Okay. Okay. So basically, if we're looking for a tumor marker, what we're going to do is we're going to have a piece of the tissue on here. We're going to have a tagged antibody to that particular tumor. We're going to incubate it, and we're going to wash it so that if there's any marker, so if there's anything floating around, we wash away any excess that's hanging around. We can also do this with a sandwich method, where we put the antigen on here, we put the patient serum, and then we put a fluorescein dye labeled anti-human globulin on there, we wash in between each of the steps. And then we look at it under a fluorescent microscope. Here's our indirect one. Again, the direct and indirect method, regardless of what your phase is, regardless of whether you're doing it in a liquid phase or whether you're doing it on a solid phase, whether you're doing it with a latex particle, whether you're doing it with a glass slide, or whether you're doing it with a plastic microtiter well, all of the reaction theory is the same. What differs is what I'm hooking it to and what I'm reading it with. Okay, so I can do a competitive, non-competitive. I can do a direct, indirect. Okay. In this particular case, I'm going to look for a fluorescence. RIA, in the 70s, this was like going to be the next big thing because radioactivity was like really, really awesome at that point. Everyone was so excited, oh, we can measure radioactivity. Then they realized they had to get rid of all of it. And the regulations on working with and getting rid of nuclear material is unfun. One of the big reasons we used these, we used a radioactive isotope of iodine, I-125. It was used for a lot of drug levels, a lot of things like that, because it was much more sensitive and much more specific than anything that was out there at the time. Okay, we were able to measure tiny amounts of radioactivity. You did it the same way. You took a tube or a slide or whatever you're going to attach to, you attached your stuff to it, you put the patient in there, you let it incubate, you washed it, you then put a radioactive tagged antibody in there, and then you measured it for radioactivity. Unfortunately, working in that room, you had to have a little radioactive badge to make sure you weren't getting too much. And then when you get all done, everything that was done in that room had to be disposed of as radioactive waste, including gloves, paper towels, all of that. And it turns out that it's really expensive and really, really highly regulated to have to deal with that stuff. So this very, very much went out of vogue very quickly. There are still a few tests where it's the only thing that really works, but they are very, very, very few, and they are done in very specific reference labs. The kind of thing that we would send it to our reference lab, who would send it to their reference lab, who would send it to this lab. You know, so they're very specialized labs, and they pretty much don't do a whole lot with this anymore, simply because it's a lot easier to use the blue stuff. The blue stuff lasts a lot longer, it doesn't decay, even though the half-life of iodine 125 is pretty long. But it doesn't decay, it doesn't degrade. Shelf life on these things, I mean, I can have it in my bathroom, you know, it's not dangerous. I don't have to worry about my kids being around it, I don't have to worry about the MAs being around it, or the doctor, or my patients. I can have it in my patient not waiting room, but in the patient exam room without having to worry about, am I exposing people to radioactivity. So this one, like I said, it was really in vogue. It was one of the first immunoassays out there, okay? Any of the immunoassays just depend on what you tagged it with. We just happened to tag it with radioactive material. Because, you know, it was the 70s. Radioactivity was the in thing. This was exciting. We just, then we learned more and more about radioactivity and how it's just not such a good thing. So we replaced it with our enzymes. And we had done agglutination reactions for a long time, but we were able to, like I said, it was agglutinations that we did before. We're done with animal. Okay, and when we talk about mono, we're going to talk about absorbed plasma with guinea pig and sheep and horse and ox, and it gets real fun. I've been practicing that lecture for the last 2 weeks, trying to get it down straight. But we did it with that kind of stuff. So anything we could do was more precise and sensitive than doing it with polyclonal animal source. As monoclonal antibodies, became available, as we became able to take them and stick them on a latex particle, as we became able to label them with the enzyme assays, it became a much bigger portion. The lab you guys are going into, you'd never have seen a lab without enzyme assays. They're just everywhere, they're ubiquitous. As I was getting out of school, they were just coming in, and they really took over. In the 1940s, serology took over from the old school methods. So science progresses, medicine progresses, you gotta progress with it. So, you guys will probably never do radioactive stuff. We don't want you to do radioactive stuff. All right? That's pretty much it for testing methodologies. That's kind of the second section. That's what's going to be on next week's test. 10 o'clock, let's take a little 10-minute break. 10 o'clock, come back, and we're going to review for the exam tomorrow. Go over what's on it. Basically, while you're on the break, and make sure that I've got everything covered. So everything we've done on the testing methodologies is going to be on next Wednesday's test.